Hello, everybody. Welcome back to the podcast. We are joined this morning by Robert DiGeronimo and Sarah Keane. Bob, Sarah, thank you for coming on the podcast. Let's put Sarah's microphone close to her face, and you have to be uncomfortably close to the microphones to minimize the background noise.
Good to know.
Can you maybe introduce yourselves in terms of where you're from and what kind of role do you play within the CHNC or it's one of its focus groups?
Yeah.
Go ahead first.
Okay, sure. I'm Sarah Keane. I'm a neonatologist like many of us, and I work at Emory CHOA in Atlanta.
Cool.
I guess my big roles is I'm one of the co-chairs of the CDH focus group with Teresa Grover, who is, one of the bright lights of CHNC, so I get to ride on her coattails. And then I am, eager member of the ECMO focus group. I'm actually not one of the co-chairs, so that's Natalie Rinsler.
But it's not an automatic. It's not because you joined the CDH group that you're automatically enrolled in the ECMO.
No, I like that too. I mean, if you don't like both, you're in real trouble. I think. But,
There's a lot of overlap.
That's right.
There is quite a bit. So Natalie is actually the co-chair with Bob, but she's actually not here. So.
Fine.
So that's me.
And then I'm Bob DiGeronimo. I'm at University of Washington, Seattle Children's Hospital, and I got involved with CHNC, I guess, shortly after I got out of the military, and I was in Salt Lake before I was in Seattle, and they were a fairly early member of CHNC, something like 2012 or so, and then, just really enjoyed being part of CHNC, and over time, there seemed to be, a space that was kind of missing for a lot of what we did with ECMO, and Natalie at CHOP, we kind of got together, talked with Jackie, and created the ECMO focus group.
Very cool.
I think like 5 years ago or so.
Okay.
And then I've been pretty involved since then.
And you're a neonatologist as well?
I am a neonatologist,
Cool.
Thanks for reminding me.
When you're at a conference, it's like you're on vacation, right? You have a different identity.
But here we have to make sure we ask.
because
There's
so
so
many
many
people,
different
engage.
specialties, and of course.
Right.
We have lots of questions about the focus groups, but I wanted to take advantage of your involvement with the CHNC for now over a decade, and maybe you can talk to us a little bit about how you've seen it grow.
Sure.
The positives that it's brought to
I
your
think
practice.
it's been really exciting to see it grow from where it started, and now with having I think it's like 46 sites and growing every year. But I think when you're primarily based at a children's hospital, having that network of people that you can reach out to about difficult cases, or how do you do this, or if you experience this, it was hard to really find that group, and you always have kind of friends that you make along the way, but I think to me that's been the best thing over time, and then also as the other focus groups have grown, I think those networks of having people that at other centers and that you can reach out to and you can talk to once a month about how you doing this, and just that knowledge sharing to me is really the best thing about CHNC, where it's not like we're not going to tell you what we're doing, and it's just super collaborative. And that's what I think I liked from the very beginning, was just, people were very open and, wonderful about sharing how they did things, and it just, I think, makes everybody better.
I agree with that. Yeah.
That's something we haven't touched about. We've spoken to many focus group members, but you guys are meeting, it seems like in every focus group, at least once a month, some groups more often.
So we're once a month. Some of the I think CDH,
is twice a month,
yeah.
usually.
A few
canceling
cancellations here.
Monday.
And there.
We're all too tired after this week, but usually we're twice a month.
Yeah, I mean that's a not an insignificant investment, to bring to your units. Yeah.
Well, and Bob is famous for, I think, being in all of the original 7 focus groups or so.
Yeah, I had a...
now he's not
The Roger
able.
Federer of the
Yeah, he
CHNC.
really is.
That was a
He's-
running joke for
he's
a
actually
number
well
of
known.
years.
Yes.
What
There's
were
too many now.
what were the original 7?
Let's see. There was... thanks for bringing that up.
I mean,
It was CDH, NEC, the HIE group. There was a group that's called the PACE group now. That's palliative care and oriented, but it was called the mortality group. I don't know if you heard that. And then they decided that was a bad name.
Yeah.
So
right.
Fair enough.
I think, and then the gastroschisis group. Yeah. I wasn't part of that, but one of my coworkers at Children's runs that. So.
Yeah.
and the BPD, I think.
Oh, and BPD, yes.
which you're also in.
Yeah. Pretty involved with BPD. Yeah.
And that makes sense, right? Because you really started to look at what are the things we get, referred in most about, but still don't have enough numbers individually to study.
Yeah.
And now it's grown
Yeah.
extensively. I saw all those tables at the focus group fair.
Yeah.
Yeah.
Well, I think it's kind of for those same reasons, where, again, for all those diagnoses that, you certainly have those patients at other hospitals, but, you tend to get, that's your primary population at, these freestanding referral children's hospitals. And again, being able to, have expertise and a lot of patient volume in those areas really, I think, allows you to, take better care of your patients when you reach out to other people. Because, we're all better when we don't do it by yourself.
Totally agree.
Yeah.
I think one of the aspects of the CHNC really shines in the CDH focus group because it is a pathology that we all see fairly rarely, thankfully. You rarely walk into a unit and there's like 12 babies with CDH, thankfully. But despite the scarcity of the pathology, because of the collaborative efforts, the work that you guys have been able to put out includes a tremendous number of patients, which is always quite impressive. I think we were looking at some of the posters also this time around. Hundreds of patients with CDH, which before the era of collaboration would have been impossible to even conceive, to put that together in a synchronous fashion.
Yeah, I think we're currently, since 2010, it's like 3,600 patients with CDH, which is, like a crazy number. And no one place has anything like that. So, and it really lets us look, even within CDH, at like smaller groups that would be small at any one place. We're doing a project now on CDH and congenital heart disease, sort of coexisting. And, usually you have 4 patients with that, and it's hard to gather anything.
Yeah, when you're looking for 2 inclusion criteria, then the
Exactly.
numbers
They're
dwindle
both
down.
rare.
Yeah.
So the numbers on that look like, there's going to be real numbers that we can actually get some information. So it's really great.
What are some of the things that you guys have been able to look at that you're quite proud of in terms of how you've been able to move the needle forward and how we take care of these babies today when it comes to CDH specifically?
Yeah, I think one of the things that's really nice about it, because CDH is, like a popular disease, right? There's the CDH study group. It's not more than, say, gastroschisis or some of the other things. There are people that are interested in it, but CHNC has so much broad data on nutrition, central lines, infections, things that some of those other groups focus a lot on the cardiorespiratory, which is super important, but the other stuff is probably just as important. And we have information on that those groups just don't collect because the CDH database the CHNC database has so much information. So.
Yeah, I think there's so many aspects to the care of babies with CDH that we can think of, whether it is pre-repair, whether it is post-repair. I think how they do feeding-wise afterwards. There's so many aspects of it that could be investigated. I'm wondering right now at this meeting, what kind of priorities are you guys setting for the future in terms of what needs to be investigated sooner rather than later?
Yeah. Everything. No, yeah, I don't know. I think nutrition is still a big focus for us. One area that I'm personally really interested in is care for the babies after they're repaired, sort of as they're recuperating, especially ventilator and respiratory support management. Every place now everyone has a protocol for delivery room care, the early days, but almost no one has a protocol or one with any data for after that. So that's another thing we're going to put our heads together and look at. And then I think, it becomes popular every 10 years or so, but like hemodynamics and CDH, right? It's really complicated, and you can really, either do great or not.
Right.
So that's the other thing we're kind of looking at right now. So.
I think there also the whole, where does ECMO play? What role does it play with CDH? It's pretty consistent in most databases that about a third of CDH babies will end up on ECMO, but it's a little controversial about how you use it, when you use it, when you repair on ECMO. So I know as we've had a lot of overlap between CDH and ECMO. And there's been a movement to, maybe put these kids on sooner and repair them sooner, but is that really the right thing to do? I don't think we really know that, but I think that's opened a lot of collaboration and discussion about, really what is the best approach. And the other thing that's really nice too is that is one disease that the surgeons are pretty heavily involved. So I think within CHNC, what I like about the CDH group too is we have a lot of pediatric surgery people that participate. And when you go to the different, CDH meetings, CHNC I think has had more of a presence moving forward. I was going to ask you, the CDH International meeting is in Lille, France, I think. And
a very big cardiac city, Lille,
but that, I think there will be a pretty good representation from CHNC there, and again, not just in our country, but it is one of those diagnoses I think that crosses.
Is that something you guys are thinking about, looking beyond the U.S. and trying to establish ties with other groups that are working on CDH around the globe? Yeah,
no, that for sure, and that's the same with ECMO too. I think there's Euro-ELSO, and Europeans, a lot of them come to the meetings in the States, and not just, but also like South America, other parts of the world, Asia, and I think we're seeing that more with CDH, where people are trying to work together.
Yeah.
Can you tell us also a little bit more? Obviously, you guys have a lot of crosstalk, but some of the other pathologies and other things you guys are looking for in the ECMO group specifically.
Yeah, I think because ECMO, like if you do 10 cases a year, that's probably like high volume for a neonatal center.
It is, even though it doesn't sound like it. Yeah.
Recently...
That sounds terrifying. 10 ECMO cases a year. And you really kind of have to be part of a larger ECMO program in your hospital, right, where you just can't do it as neonatology anymore. You have to collaborate with your PICU friends, as painful as that can be sometimes, but they're actually
or
pretty
the
nice.
CI.
Yeah, the CI, that's kind of a step
painful.
up. Yeah.
Just kidding.
But it is also one of those things that I think...
So much room for improvement, right? Communication with our colleagues.
But within your children's hospital, it's nice because I think you get to know those people and you share a lot of resources. But recently there's been a lot of issues with equipment and supply shortages. I know we've seen that with medications, but in ECMO specifically, the circuits and the different oxygenators, there's been a lot of shortage, or manufacturers have kind of stopped making systems, and and a lot of the stuff with so much adult ECMO now. They just don't design things that are specific for neonates. So I think for us, a lot of, the new equipment or technology that comes out, trying to sort through, what actually works for neonates and is it safe to use in neonates has become really, really important. And, Sarah's done like a tremendous amount of work with doing VV ECMO versus VA ECMO, and they're, clearly a leader in that at Emory. But, for 3 or 4 years, we had, the VV cannulas that fit neonates were off the market. So I think a lot of centers that did neonatal ECMO kind of forgot how to do, VV ECMO. And that's actually one of the workshops we did here, and we actually did it last year and was really popular, was teaching, neonatology how to, do VV ECMO again, because now because the new cannula came on the market and has been out, and that's been a great collaboration. Brian Gray, who's a surgeon in Indiana, we've been pulling our cases together, and we're planning to publish that. But I think we learned there were some definite kind of little nuances of how you use it. But to me, that was a great example is how, when that came back on the market and we kind of all talked to each other and, oh, this didn't go well, but this went great. So that's been really important work that we've done recently.
Yeah, and the workshops are so valuable because even if you're saying 10 a year, right? If you don't have a dedicated team, and some units don't, so everybody cycles through, you may only see one or two on your service time. So I think even for those of you who are seeing a quote unquote lot of it, that's so valuable to have those hands-on opportunities.
And a lot of there's been kind of creep with neonatal ECMO too, where hospitals they've kind of just put those kids in the PICU, and it's not that they don't know how to take care of ECMO patients, but it's they don't, it's a different population and all the stuff that goes into caring for a CDH or a neonate, those sorts of things, can get missed depending on what sort of collaboration you have within your units. But there's been a real movement, I think, within the children's hospitals to bring ECMO back into the NICU primarily. And I think we've, at CHNC, have really played an important role with helping centers, using our experience to say, this is how you bring it back in. This is the training you should do. And that was part of what we were talking about at our workshop was, doing neonatal specific simulation to, kind of reteach us so we can safely do it. Because I do think, and I think we kind of, as neonatologists, believe those babies, are better cared for in the NICU if you can do that at your center.
I think the HIE patient on ECMO is the other group. It's, we've been doing that and continuing cooling now in most of the NICUs for, 5 or 10 years. And really, we've had pretty good outcomes. Like some kids actually normal at follow-up, you know, and it, but when you see those babies cared for in the PICU, there's, not the knowledge we have about how good, especially the moderate HIE patients can do in terms of outcomes. And so they have a lot of doubts about even about candidacy, which we had 15 years ago, to be clear. And so I think that's one, at EuroELSA anyway, the most of the questions I got from PICU doctors were PICU doctors taking care of NICU patients and uncomfortable about HIE, and that's actually a huge group right now. And like cooling and managing all of that kind of stuff, that I don't know, that's easy to do wrong too.
And we actually did publish a paper from our experience showing that that's one of the areas where VV is better than VA, and you have less brain injury, and so I think that was an important message. If you're putting these kids on, if you can do VV, that's better.
One of the things that you guys brought up at this year's symposium is potentially looking at how can we incorporate precision medicine in CDH and thinking about maybe how we can start triaging patients based on risk severity and trying to think about calculators. Can you talk a little bit about what that project may look like? Because I think it's something that we would not even have considered in the past to actually be able to triage patients with such a rare condition. But now, thanks to the large data set that you guys have and the years of experience, you're actually able to maybe classify patients with CDH based on risk factors, which is kind of impressive.
I think we have some of the information, but we don't have everything.
Fair enough.
The thing you learn, even as you look at these big groups, is that, you get OE, LHR, you get these different numbers, and those just don't tell the whole story.
Right.
You get information on the cardiac status, those kind of things, but you're missing part of it. So I do, and I don't really know where that's going to go, but I think we have like 60% of the data on who's going to do well, but we're missing this big chunk that is, genetic or something, that we need to figure out. And CDH, like isolated CDH, often haven't historically gotten like genetic testing or any of that kind of stuff, but it's a big anomaly, and I think we'll start to do more of that, and then maybe figure some stuff out.
For me, being on the outside, it does feel like though the goal is in reach, though. I feel like maybe not today, but I feel like in the few years we'll be able to get there. Is that misplaced?
I think we're going to make progress.
That's good.
And then make progress.
We're going to learn that
and
in
then
France.
Yeah.
The French are going to teach us.
And then in 20 years we'll be like, I can't believe we did that.
That's
years ago,
yeah,
because
but
that's how medicine works.
But
right?
even the things you're talking about right now, LHR and stuff like that, things that we've used as dogma for how do we think about these patients, we're rethinking already, which is a huge step in the process of establishing a new way of thinking for these patients.
Yeah. I mean, in the pulmonary, vessel remodeling, right? I mean, it's so complicated and it's not anything like anyone else.
Right.
And it doesn't fit with severity like it should,
Right.
So that, I think that would be huge. Like which medicine, we're basically just putting sequential pulmonary hypertension meds on to see which one works, hoping one does. And it would like to have an idea what was going on in a particular patient and which one is most likely to work. I mean, right, that would be incredibly helpful. So, because sometimes we end up on 4 and we're still not any better.
Right,
So,
right.
Right.
Yeah. We feel better at least that
We feel like we tried, and that's okay.
Yeah,
But
yeah.
But I think also the, to your point, Ben, like identifying, who are those really sick patients, and the whole fetal therapy. We have a fetal therapy group at CHNC, but, how that fits in, and what is the benefit, and trying to have those markers to identify, the sicker patients that really should deliver at a children's hospital. But it's also allowed, I know at our center, having, pretty really low risk CDH patients, if you have a big catchment area, having a family travel from Alaska or Montana to Seattle is a long distance. And if you can identify, patients that are low risk, that are going to do well, and they have pediatric surgeons, I think it can allow those families to stay home and
minimize the trauma on the family.
Yeah,
for sure.
yeah, and I think that's
Huge.
the other end of what's low risk that we can
absolutely.
safely maybe take care of in the community.
I love that. Well, Bob, Sarah, thank you for joining us today. We've learned a lot, and we're looking forward to seeing more articles coming out from your groups.
Yeah, thanks for having us.
yeah, thank you very much.